right, I think Dr. Rebecca Flyckt was already introduced this morning, so I'm not going to reintroduce her, but she is going to talk to us about uterine transplantation.
Terrific. Thanks, Molly. Just a quick disclosure. I know in the program it says that I'm from the University of Michigan, but I think my credentials might have gotten switched with Molly, which if there's somebody to get switched with, I'm very happy with that. But I'm actually in Cleveland. I've spent my career in Cleveland. And currently I am at University Hospitals of Cleveland, Case Western. I'm the section chief of reproductive endocrinology and infertility, and I'm the medical director of our IVF program. But for this talk, I'm really wearing my reproductive surgery hat, which is something I've spent my whole career doing and is really my life's passion. And so, go blue. I did go to U of M, but I am in Cleveland. But I just wanted to thank you for having me here again in the afternoon. I have just been fascinated to hear so many amazing talks by friends and colleagues around the world. This is truly one of my favorite meetings, in part because it's small enough that we really can exchange ideas. I'm coming home with so many thoughts about what I want to do next, so I hope that's the case for you guys too. So I don't have any financial disclosures, but I did want to disclose what you kind of see pictured here today, and disclose the fact that this was, like, outside of the birth of my own children, probably one of the happiest days of my life. This was the birth in 2019 of our first deceased donor uterus transplant baby. It was actually the first in the United States. And I won't say that it was the happiest just because it was like the result of 10 years of my life and blood and sweat and tears, and for the team. But really because of this woman's story, which is the story of so many women with Magee-Women, where she was told in a really perfunctory way by her gynecologist after doing like a 1-minute exam that she was born without a uterus, that she would never have kids, that she would never be a mother, that she might not be able to get married, because who would want you if you can't become a mother? And this transplant and birth was really the result of a life of longing and a dream fulfilled for her. So it was a really big day for her, for our team, for the institution at Cleveland Clinic, and for the entire Magee-Women community. So I just wanted to disclose that before we launch in. So uterine factor infertility is something that many of us see in our practices. I think we're all pretty familiar with the 1 in 4,000 quoted prevalence of Magee-Women, which again are women who are born with ovaries, born with all of the normal, typical reproductive system elements, but just don't have that uterus. And this is what it looks like when you do a laparoscopy and you look in and don't see a uterus. And importantly, these women typically do have ovaries. They are able to make eggs. They can lead to healthy pregnancies. But in the past, there really was no cure for this condition. And that was part of the issue. There's workarounds, and we do that in our IVF practice all the time, but there really wasn't any true treatment. But when you think about that 1 in 4,000, that really underestimates the rate of uterine factor infertility in the United States. It may be as high as 1 in 500 women if you think about all of the different contributors to not being able to carry a pregnancy, and that might be 3 to 5% of reproductive age women around the world, which would translate, doing sort of a back-of-the-napkin supply and demand to maybe 1,000 to 2,000 uterus transplants a year once we're really fully in motion. It's not just being born without a uterus. It's all the things that happen in medicine. We are very hysterectomy happy in the United States. We do a hysterectomy if you have obstetrical complications. That's, a necessary thing. Or if you have a pre-malignant or malignant condition. But we also do hysterectomies for everything else that brings you into a gynecologist's office. Pelvic pain, abnormal bleeding, endometriosis, fibroids. In the US, we just take your uterus out. That is not the case in the international community, but that's certainly something we've observed here. And so I put at the bottom here the two organizations that have kind of emerged around the world. One is the US Uterus Transplant Consortium, and the other is the ISUTX, which is the International Society for Uterus Transplantation. And these are two entities that weren't here 10 years ago. And so it's been kind of amazing to see that for this group of women who have felt so underrepresented and really felt like their voices have not been part of this discussion previously, to have two organizations that are innovating and advocating and advancing the science of reproductive surgery for women with uterine factor. So this is kind of an international crowd, and this is initially going to focus on the U.S., but then we'll go out globally. And I think it's really important to look at how gestational carriers are legislated around the United States. And it's important to know that there's actually very few states that have specific legislation that's supportive of gestational carriers. And then in a lot of places, there's no laws or there's some loose restrictions. And then in a few places, it's actually banned or penalized. So like many things in the U.S., this is really a state-by-state designation. And so this is why the U.S. was a little bit slower to pick up on uterus transplant when you look at our colleagues around the world. And even if it's not specifically legislated, there are many people for whom the idea of a gestational carrier is really just not personally, religiously, philosophically, something that they really are on board for. And I always think about a patient of mine who had her gestational carrier on labor and delivery. You know, the obstetrician was recommending a C-section, and the gestational carrier initially refused. This was surgery on her body. She got to refuse. And I can only imagine how it feels to be that parent with your child in labor, having what kind of obstetrical stress and not really being the ultimate decision maker over what happens to that baby. So when I first started giving these talks, there was a lot of opposition to uterus transplantation, and I think that over time that has started to change. But I still have in these slides really what the why is, like why would we do this highly experimental, sometimes risky procedure, and this is part of the why. So even though gestational carriers can be accessed in the United States, although not necessarily easily, if you look around the world, you actually find that the U.S. does not mirror the rest of the world. Around the rest of the world, especially, for example, in the Middle East and Sweden, which is where uterus transplant initially arose, having a gestational carrier is not really a viable option. In fact, many people around the world think of a gestational carrier essentially as human trafficking. And this is likely the reason that Saudi Arabia and Turkey were some of the first places. Now, those did not meet with much clinical success, but now we're seeing it spread, to many of the countries and continents around the world. So how did this innovative procedure first arise? And the answer is it's not as fast as you think. There was a lot of research that happened in the 90s that started to intensify, initially with animal models and then moving on to human studies. And the first two attempts, the first one was in Saudi Arabia, and then the second one, almost 10 years later, in Turkey, were really outside of an experimental protocol, outside of ethical review. These were very talented, very experienced surgeons who felt that they could take this on. But it wasn't until it moved to Sweden, and I feel like I can say this, I mentioned this morning, my husband's from Sweden. There is sort of a national character that's very methodical. And I think that approach was what really helped to move the needle on uterus transplant that resulted in the first live birth. So they had a structured clinical trial with ethical and institutional oversight. They enrolled women. They followed them in a very measured way. And that was really kind of what got uterus transplant on the map. And I don't know, for those of you that are REIs, this is Matt Braunstrom, who is pictured in the middle there. And he really is sort of the father of modern day uterus transplant. So at ASRM, he was honored. There was a standing ovation. I mean, as a reproductive surgery, this is just an incredible game changer for our patients. And then after that foundational work, we really saw that uterus transplant evolved and also that the pace of innovation escalated. So that first uterus transplant that was performed in Saudi Arabia that unfortunately was unsuccessful and they had to take the graft out, that was, many years before a subsequent attempt in Turkey. And actually, interestingly, and I didn't mention this, for the longest time on this slide, I could say that the patient had had multiple miscarriages but never gave birth from a deceased donor model, similar to like how we do a liver or a kidney. But actually in 2022, 9 years later, she finally gave birth. They identified an outflow obstruction, were able to do a venous graft from the saphenous vein. So she ultimately did have a live birth and was really sort of technically the first successful deceased donor transplant. It was just much later. So again, this is the timeline, and you can see that there's just steady progress. starting from the earliest stages and then moving to clinical trials. Ours was the first clinical trial in the United States at Cleveland Clinic. Then there was a first living donor uterus transplant live birth that happened in Sweden, and then eventually Baylor also had a living donor uterus transplant live birth. Then came the minimally invasive approaches, just like throughout most of gynecology, where laparotomy moves to laparoscopy, moves to robotics, and that's exactly what we're seeing with uterus transplant. And then the first deceased donor live birth, which was in Brazil, and then we had the first deceased donor live birth in the United States in 2019. And now we're getting to the next phase, which I'll talk a little bit more about. You know, in Germany, they've now accepted it as a standard of care treatment, and that's something that's paid by the government over there, which I think is pretty outstanding. And we've started to build registries both in the United States and abroad. Uterus transplant is not a quick and easy undertaking. You know, compared to what I am able to do in terms of banking ovarian tissue, uterus transplant is something that you have to take the long approach. Patients might be in the system with you for 2 to 5 years, preparing for the transplant, banking embryos with IVF, starting the transplant process, getting matched, making sure the transplant has settled in without, you know, initial severe rejection, and then the clinical follow-up, pregnancy, delivery, and it really doesn't even stop there because we're just at the beginning of starting to collect neonatal outcomes. And when you think about how long it took for us to get ready with innovations in IVF and then looking at live birth and impact on offspring, we're just starting to get there with uterus transplant. So where are we today? And where are we in the United States? So worldwide, there have been more than 80, at this point I would say probably closer to more than 90 uterus transplants that have happened rapidly over the last 10 years. And although I kind of throw out success around 50%, you know, what became clear to us in the experimental phases is that there is a learning curve and that experience really matters. And so there's a lot of failed grafts at the beginning, bleeding, infection, thrombosis, just like they saw with liver. But over time, and based on the expertise as a center, you can really get to a solid workflow. So we're still gathering data, but there are more than 40 live births that have happened from uterus transplant, and so far, touch wood, most of those live births have been healthy. But I think it's really important to kind of separate the difference between multiple anecdotes, which is where we started, like, hey, I did this and we got a baby out of it, and then data. And so we're getting to the part where we really need to start looking at the data in aggregate to make sure that this is safe, that it's effective, and that it is giving us healthy deliveries. So that's a picture of me with the baby that we had back in 2019. And so I wanted to put this up here because, you know, IVF is a huge part of what we do, all of us do in REI, and really compare this 10 years of uterus transplant with 10 years of IVF. So many of you probably know that Louise Brown was the first IVF baby delivered in 1979, and that was the result of a tremendous amount of effort from 1969 to 1978. And if you look at the tally, it's 250 patients, you know, almost 500 cycles, embryo transfers, clinical pregnancies to get to 2 live births. So if you think about this as a live birth, you know, per embryo transfer, it's a 1.8% success rate. So when people tell me like, oh, uterus transplant isn't ready for prime time, this is our history with IVF. So just a quick comparison. And I do think when I go to meetings, you know, on uterus transplant, it feels very much like the early days of IVF. It's a small group of people that are really passionate and committed to this, sharing data, sharing techniques, helping each other evolve, all for the good of the patient. Now, to bring it a little closer to home here, because many of us are doing ovarian tissue transplantation, you know, how does that look different in terms of its trajectory of evolution from uterus transplant? Well, you know, ovarian tissue transplantation has been around since about 2004 when they had the first live birth. Uterus transplant, 2014, so not too different. Total live births, and I'm sure someone here will debate me on this, you know, more than 180. Uterus transplant, more than 40. So in a very short time, we've come a really long way compared to how long it took to get aggregated data on live births from ovarian tissue transplant. Now, that probably has to do with the age of the recipient. You know, when we're freezing ovarian tissue, this is often in children and young adults. It's really hard to know how many procedures have been performed, what's the denominator, but I think that in uterus transplantation, we have a much more discrete number, and it's probably somewhere between 80 and 100. Ovarian tissue transplant, no longer experimental. Uterus transplant, transplant, a lot of debate about whether it's a clinical reality versus an experimental treatment. And then you can continue to compare them. Does it allow you to have a biological child? Yes. What's the success rate? Kind of hard to say depending on the study. Are there endocrine benefits? Yes, with ovarian tissue. No, we don't think there's a lot of hormone benefit to the uterus. And then, does an ovarian tissue transplant require immunosuppression? No, or unless you're Dr. Silber's patient that he presented, who had a sister that gave an ovary. But uterus transplantation does require that. And that was one of the biggest initial concerns, which is, okay, similar to a liver or kidney, we're putting people on established immunosuppression protocols for solid organs. We do that all the time in obstetrics, but is that going to be okay? Is that going to be safe for uterus transplant? And so far the data are very reassuring. But the graft is only intended for the reproductive lifespan of the patient, somewhere in that 2 to 4 year range. It's not meant to be lifelong because immunosuppression, although it's overall seeming to be okay for the baby, definitely is not okay for the maternal kidneys long term, and we are seeing some renal insufficiency. So how do we approach the surgery? All of our usual gynecologic landmarks, and I won't belabor it, but for a deceased donor, the really cool thing is that, I can take the entire iliac artery and vein. I can take the external iliac. It doesn't matter, the patient's deceased. But the majority of data that we have about uterus transplant is from living donors. So with a living donor, you have to be much more cautious, and a lot of your dissection, at least in the initial techniques described, were in the area of the uterine artery and the uterine vein. For those of you that do surgery, uterine artery is actually pretty easy to identify and dissect out, both the proximal and distal portion. The uterine vein is very tricky, and this is what's responsible for many graft failures. So this is just one article pointing to all of the differences in the anatomic presentation of the uterine vein, and there's probably even more that are here. And that's what made this very difficult, was identifying it, dissecting it out, and making sure that you had outflow for the uterus that was sufficient to prevent thrombosis, because thrombosis and graft failure go hand in hand. This is a CT angiogram looking at the different vessels to the uterus. And again, uterine artery is pretty clear. Uterine veins are very complex. And so this is one of my favorite videos. This is just looking, I don't know why it's still stretched out, but looking at reperfusion of the uterus. So you can see the uterus front and center. It's a dead organ. And then as you look at the right of the screen, you start to see that blush of reperfusion, starting screen right and then slowly moving towards screen left. And this is, if you ever have the opportunity, like one of the coolest things to participate in, because you take a uterus that is cold, dead, white in a bucket, and then it starts to come to life, and it's able to give life. And I think that's what's so incredible about these transplants, is that, no, this is not a life-saving transplant, but this is a life-affirming transplant. This is a life-generating transplant, and I think that that is really where the magic is. So we've started to collect our U.S. experience from the Uterine Transplant Consortium that we formed, about 5 years ago to take a look at our data in aggregate. And basically in the United States, we've done about 41, 24 living donors, 17 deceased donors. Ours, when I was at Cleveland Clinic, was a deceased donor program. And you can really see an increase in deceased donor transplants going right into COVID. And then 2020, 2021 was a quiet time for us in the uterus transplant community. And then you can just see that things are starting to reemerge. And I think as this graph goes on and we get complete data from 2023 and onwards, what we're going to see is that there are a lot more deceased donor transplants. There's been a little bit of a tick down in the living donor transplants, and that's because, the heaviest hitter in that area was really Baylor, and they did it within an experimental protocol, and now they are actually offering it as a clinical offering for a cash price. And so I think it will take a little bit longer for those numbers to start to accumulate again. There's a big difference between getting it for free in an experimental trial and writing a check for your uterus transplant. But there's 4 active centers in the United States. All of them are doing phenomenal work. It's University of Alabama, Birmingham, University of Pennsylvania, Cleveland Clinic, and then Baylor. So how to assess the success and efficacy of uterus transplant? This is something we talked about a lot. And basically, I'm just making sure, is that my time on the slide there? Okay. Basically, the most important thing is the mortality of the recipient and the donor. And I'm very pleased to say that there have not been any deaths for recipients or donors from uterus transplant. When you're operating on these patients, you're very aware that this is a young, healthy, reproductive aged woman, and the stakes are very high. I'm not a cancer surgeon where if you make a hole in the bowel, they thank you for curing their cancer. This is a fertility patient, and so the bar for complications is very different. As far as the technical success of the procedure, overall, in some studies it's been as high as 76%. And what I mean by technical success is, does the graft stay in situ usually longer than a year? And there's basically a couple things that will sink you in the first 7 days, and that's usually when we have to remove the graft, and it's either excessive bleeding or a clot that blocks the outflow to the organ, and it thromboses and dies off. So what's really interesting looking at technical success is that from 2016 to 2018, there were 8 patients out of the total of 41 that had to have a graft removed, and that's really a sad thing. However, from 2018 through 2023, there have been 0. And I think that just speaks to, for any innovative surgical procedure, as you go along, as you gain experience, as you adapt and innovate, it becomes much more successful. And that would be my advice for anybody starting a program, is to do as much practice and preparation as you can using deceased donors in a controlled environment, and then move it forward with living patients. And so really there have been no graft removals in the United States since 2019. The reproductive success is a lot harder to kind of get your hands around in terms of success rate, so I'm just going to go with sort of the sine qua non, which is live birth. So basically, for people that get through that first week and then first year and the graft remains in situ, how many of them are able to have a baby? And by about the 2-year mark, about 73% have had a baby. By the 5-year mark of those that have an intact uterus, 90% have had a baby, which is really exciting to be able to share. So again, we're taking that long view. Not everyone's going to get pregnant right away, but most people eventually do achieve a live birth. There was a high rate from the US UTC report of preterm delivery, about 63%, but what I'm going to share is that that is also evolving. We delivered our first baby a little early, mostly because we were very nervous and her creatinine was starting to increase. We knew that there was a placenta accreta, and so we did take the baby a little bit earlier. But as we go along, as we get more comfortable, as we can have reduced immunosuppression protocols that may have less AKI, I think that we will start to see, as you do in this graph, that most babies are going to be delivered probably between 36 and 38 weeks. Now, a common question is, can they have a vaginal delivery? No, absolutely not. These are going to be C-sections. But the thing that I think about the most, and the reason that we picked a deceased donor model when I was at Cleveland Clinic, is that, it's not the mortality. We think it's very unlikely that someone will die from this procedure, but it's the complications, it's the morbidity. And I think that that is the ethical argument that people often raise when we think about the living donor conundrum. A lot of times living donors are actually relatives of the person receiving the uterus. And as someone who has 2 daughters, I can tell you, if they needed my uterus, if they needed my arm, if they needed anything, of course I'm going to give it. But is that ethically supportable, to put mothers in this situation to give their daughters a uterus? And so there have been 24 living donors in the United States. I'm sorry, that's the average age of these living donors in the U.S., because mostly these patients are coming from Baylor, and those typically were unrelated donors. Underwent laparotomy, and then over time started to do a minimally invasive approach. One of those 11, actually, I think they converted to a laparotomy. But overall, the living donor pattern showed that about 20% did have a complication. That's not a low complication rate. And there's a whole scoring system for classes. 1 is the most mild, 4 is the most severe, and 5 of 24 living donors did sustain a complication at the surgery, mostly ureteral injuries, but occasionally things like uterovaginal fistula, or even a dehiscence of the cuff. Now, recipients too can have complications, and I'm leaving out like the graft losses where we have to do an emergency hysterectomy. But I learned, because I'm not a transplant surgeon, that rejection just goes hand in hand with transplant. So at least half of our patients experienced rejection, and actually some of them even had rejection during pregnancy, which was something we really feared. And then once we'd experienced it a few times, it just is part of transplant medicine. Nobody has lost a graft, as far as I know, from rejection. There also were infections complications. The renal insufficiency is something that was published on recently. It's not severe, but it does seem to persist even after the graft hysterectomy. And then we all know that there's issues at the anastomosis with vaginal strictures. That's important because that's how we get the embryo in. It's also important because the cervical biopsies are how we monitor the health of the graft. So if your vagina is strictured down so small that you can't get your instruments in, that's a problem. So I've seen a little bit of everything in terms of complications. You know, the biggest one, and I think in residency we used to call this like a cuvular uterus or something, but thrombosis, graft removal, and this really sad uterus. I mean, you can see clot coming all the way out of the vessels laterally there. So that was one that unfortunately within the first 7 days we had to remove because of outflow obstruction. And then our first delivery, which we published in AJOG, I mean, the baby was great, but it was the worst placenta accreta that I've ever seen. And you can see a picture of it there on the table, you know, after they started processing the specimen. And it's hard to know, was that just related to IVF? Because we certainly see more accreta with IVF. Was that something related to the transplant, to the immunosuppression? You know, these are small numbers, so it's hard to say. How am I for time? 7 minutes. Okay. As far as who would enroll in a trial like this, because it is a long-term undertaking, there are risks, and at least in the United States, we do have options in most places for accessing a gestational carrier, whether it's in your state or someone else's state. So who's interested in doing a uterus transplant? And initially, I'll kind of show you towards the right. This was another publication in AJOG that we did with a former fellow of mine. And we looked at the first 239 people that applied to our clinical trial, which is offered for 10 recipients. And what was really interesting was that it was sort of a 2/3, 1/3. A third had uterine factor infertility because they were born without a uterus. And then the other 2/3 were acquired uterine factor, and that was not at all what we were expecting. You know, when we looked to our colleagues in Europe, it mostly was women with MRKH, and I think in Sweden, one with a cervical cancer. And so we were really surprised, and I think, again, that goes back to my initial thought about this culture of hysterectomy that we have, that these young women regret their decisions so much that they want to go through a uterus transplant to get their fertility potential back. But also what was interesting is that, you know, for the women that had acquired uterine factor, about half of them were for non-malignant indications, non-obstetrical indications. So again, those are our endometriosis, fibroid, bleeding, pain patients that we're doing hysterectomies for. So a lot of those women really probably didn't have to have a hysterectomy in the first place. So that was several years ago. Flash forward to, you know, a more recent publication looking at data from all 3 centers in the United States before UAB came online, and it showed that out of 5,000 inquiries about becoming a uterus transplant recipient, same pattern. So the orange line that you see at the top are women that had a hysterectomy as the reason for their uterine factor, and then the blue line, which actually we've seen steadily decrease, are the women who were born without a uterus. So it may be very different in the United States than it is elsewhere in terms of who's seeking this procedure. And then I always love looking at this data because it's totally different from the early days of uterus transplant, where people would say, these are women that are born without a uterus, they're desperate, they're childless, you know, it's going to be women coming from other countries where gestational surrogacy is not an option for them. It's just not true. Like, the fact is that the vast majority of women that apply to and then actually participate in uterus transplant trials are women that are from the United States. And even more interesting, these are women that have children. 20% of them have children. So they're not desperate. They've had a child, you know, either on their own before the hysterectomy or through a gestational carrier. They've already checked that box. But again, it speaks to the fact that these are patients who just feel that they want more options. And that's a huge, I think, theme right now in women's health, is that women want to make decisions about their own bodies. They want options counseling with lots of choices available, and then they want to be able to make those choices. So I think that that was so interesting. And as we get more and more success, we also find that attitudes towards uterus transplant are changing. So a uterus transplant is considered a VCA. In short, that's the kind of transplant that is life-enhancing but not life-saving. So similar to like a face transplant, which I have often seen. And what you can see here, you know, in the early days, we could not get anyone to consent their family member to give a uterus for transplantation when we would go talk to these potential deceased donor families. And now when you ask women about the possibility of donating their uterus, 3/4 of them are willing. Now, what you'll also see is that there is a little bit of a gender gap. Only 54% of men are willing to donate their penis for penile transplants. So get with it, guys. And then just thinking about, what's next. I think that we've established that the procedure can be done. We can modify the approach. The Baylor team, I think, mostly uses the uterine ovarian vessels. That's what gave us the first live birth from a living donor in the United States. That makes it less risky, and reducing risk to the donor is a huge priority. It's moving out of the experimental and IRB-driven phase more towards being a clinical offering. So now they're being offered outside of experimental protocols and IRBs, both at Baylor and University of Alabama at Birmingham. I think this is the time for us to really determine what's the best model. Is it a living donor? Is it a deceased donor? I think right now we're at a state of equipoise where we just don't know. And then I think that now that we've actually established CPT codes, because in the United States you need to have a code for a procedure, we're starting to continue to work on getting this covered by insurance. And I think the key to that is really starting to think about it as either a gender-affirming procedure or a correction of an anomaly, as opposed to a fertility treatment, because everybody here that does fertility knows that that's the hardest thing to get covered, even though we've made some strides. And then there are registries that are forming to start answering those pivotal questions of, is this really confirmed to be effective and safe for recipients, for donors, and for babies? And so then what's even more exciting than that is the idea that at some point maybe we won't need a donor. Maybe we will be able to build a bioengineered uterus with a 3D printer or who knows what. I think the sky's the limit in this field. And then we just published recently in Fertility and Sterility, there's been increasing and evolving discussions about the possibility of doing a transgender uterus transplant for a transgender woman. And they have, again, talked about that as a gender-affirming procedure. And obviously, it's a little bit controversial, but I do think that it will happen. I think it'll happen in the next 5 years, so you can look out for that. I'm not sure who's going to do it first, but I think that one of the concerns that I have is if we're offering it outside of reproduction, if it's a procedure that's being done for transgender women as gender affirmation, because of some of the complications that we've seen for recipients, because of the renal insufficiency, the uterus transplant was originally intended not to be a graft that lasts for the life of the recipient. It really is intended for a short term, and so ethically, what is the balance on that? In thinking about, doing a uterus transplant as a gender-affirming procedure for someone who might want to keep it, for the long term, and who gets to make that decision. So what I love about REI is that there's always a lot of really fascinating ethical questions. I don't know the answer to that, but I can tell you that I think it's technically possible and that it will happen. And then just to conclude, you guys probably know it's election day in the United States, and I'm from Ohio, so tensions are high. But in any case, in addition to this cartoon, I wanted to share with you just a final quote from some women that we interviewed for a mixed method study, because one of the trends that we're seeing is no discussion about us without us. And so I wanted to try to bring the voices of a patient born with MRKH into the discussion, and this is just one quote. But being able to give birth, able to hold your baby in your body for 9 months, all the joy that comes with it, the connection, the attachment, the accomplishment, these are just a few of the things, but I'm sure there's many, many more aspects of how it can benefit your self-esteem, your womanhood, how it can benefit your perception of your own self. Because everybody who has this disease, the condition that I had, who's had to have the conversations that I've had, it's about having very low self-perceptions, and it affects our consciousness and our ability to look at ourselves the same way that every other woman can look at themselves. So I just appreciated her being so upfront and honest about what it's like to live with MRKH, and I welcome any questions that you have. Thank you.
Thanks so much. We have time for one question.
Hi, thank you for that. That's so interesting. I have just a thought, maybe not necessarily a question. Isn't it ironic that Texas and Alabama, are some of these leading spots? I mean, what happens if you have a uterus with a fetus that's growing inside of it but needs to be removed for the health of the mother? And has any of those politics impacted, what they're able to do?
Yeah, what an awesome question, and on a particularly good day for it. So I think, yes, it has. So one of the debates that we have in REI globally, not to do with uterus transplant, is when and whether we want to apply PGTA, which is the genetic testing of embryos. And at Baylor, they require for entry into the trial, I think it's either 2 or 3 PGTA embryos that then will be put back into the recipient. And I think it was partially because they don't want to get down that road of, what are we going to do if we have a pregnancy with Down syndrome in a state like Texas? I don't want to speak for them. But, for example, in Cleveland, we did not have restrictive legislation at that time. And so we did not do PGTA because the data show that if you're under 37, 38 years old, it probably doesn't improve your live birth rate and it may not decrease the miscarriage rate. But I think for places that live in more restrictive areas, it's like PGTA or bust, and I imagine that that's influenced by some of the legislation. Thank you.
Thank you so much.
Thank you.